I think at some point the person awoke to the fact they didn't have a finger, or someone wakes up that they're
Yeah.
missing an arm, and then they're really struggling with what they may not remember the acute trauma, the explosion, the car accident, but they're going to eventually cope with, oh, I'm missing a limb. And that's not going to be easy. So I think what ketamine does is it anesthetizes and puts a distance between the event and the awakening. And
Yeah.
that distance is made up by us as practitioners. How long do we keep someone in that state before we bring them back and they have to deal with the pain, the loss of limb, or whatever, which is going to be difficult eventually. So it's the memory of the trauma itself which tends to be lost and suppressed.
Welcome to the Two Curious MD podcast. I'm Dr. Alya Ahmad.
And I'm Dr. Alya Ahmad.
With the wisdom from holistic, alternative, and these conventional medicine, we are here to challenge the status quo.
We're curious about the connectivity and complexity between diverse fields of knowledge as they relate to consciousness, chronic illness, mental health, resilience, and beyond.
Learning more about the art and science of healing, or listening to stories of extraordinary healing. You're in the right place. Let's dive in. Welcome to the Two Curious MD podcast, where medicine is more than science. It's story, art, and connection and integration. This is a space for the curious and like to dive in. Today, we are honored to be joined by Dr. Phil Wolfson, a returning guest who is a pioneering psychiatrist, psychotherapist as well, and one of the leading voices in the therapeutic use of ketamine. He's also the founder of Ketamine Research Foundation, an organization at the forefront of really advancing education, clinical practice, and research in ketamine-assisted therapy. Dr. Wolfson has been instrumental in shaping the modern understanding of ketamine as more than just a pharmacological agent. And if you've read the ketamine papers, you would know that he has really acknowledged and really brought light to ketamine as a catalyst for healing, insight, and transformation. His work spans decades and includes contributions to clinical protocols, training programs, and a growing body of ketamine research and publication. Today, we're going to explore an exciting and deeply meaningful new frontier of his work in a clinical trial investigating ketamine for phantom limb. And I would like to make an announcement that we at Shah Minds Healing Center are a clinical site for this very important study. And I really wanted to bring light to this topic because it is a topic not really acknowledged, I think, as a treatment or even as an option for treatment when somebody has a limb or amputation and has pain subsequent to that. And this is a condition that really intersects neurology, trauma, and even the self-consciousness itself. So I believe phantom limb raises really curious questions. And how does the brain construct reality of that new missing entity? What does the pain feel like when the physically part is not present? These are some of the questions that we have. But I'd like to dive in and welcome again Dr. Phil Wolfson to this podcast today.
It's my pleasure. What a lovely introduction. Thank you,
Thank you.
Alya. Thank you so much. And indeed, you're part of the whole Phantom Limb Protocol project that we put together through FDA approval and IRB approval, a formal study of the effects of ketamine in a new protocol to see that we can demonstrate the effects of ketamine in this approach to help people with what's a really complex syndrome. It's not just pain. It's a sense of location that can be torturous, where a limb that used to exist is twisted or in an uncomfortable position, even though it doesn't exist. It, has many other kinds of phenomena, sensory phenomena, shooting pains, itches, all kinds of things that relate to the brain's preposition that the limb still exists.
The limb
Now, a
still
lot of people
exists.
think it's the whole limb that
Yeah.
is projected, but in fact, mostly it's parts of the limb. So
Yeah.
if someone, like, for example, has a amputation below the knee, it's not the whole leg to the foot that's projected. Usually, it can be, but it's often part. The pain can be extraordinary, constant. It could go on for years. It can be somewhat intermittent and then return. People may have a remission and then have a relapse. And there are, millions of people who are amputees. And amputations even extend to phantom limb breast mastectomy pain and problems of that sort. There are thoughts about other kind of phantom reconstructions that the brain accomplishes when parts are missing. So it's a pretty wide spectrum. We're focused on amputation, and I have a story to tell. Would you like me to tell a story?
Yes, I would love to hear about what brought you to this important topic.
So I'm an old investigator within the MDMA MAPS ambience. I got involved in the legal period with the revolution that MDMA created in psychotherapy in the early 1980s. And MAPS is a wonderful organization, very large, representing the interest in making MDMA legal again, at least for prescription, which is where most of the energy is gone. Still not happened, unfortunately. So anyway, MAPS has held what is now a biannual conference where thousands of people come and present and talk about the world of psychedelics, MDMA, ketamine, etc., and where I've been a presenter. And 2 MAPS conferences ago in Denver, I was manning the Ketamine Research Foundation booth, which is our nonprofit sponsoring this protocol. And a woman came up to me who had a missing below the knee leg from an amputation. I told her story eventually in Lucid News, and she's a remarkable woman. Her name is Michelle Barocchi. She's of Italian background, lives in the States, has a PhD in molecular biology, had a horrendous accident which almost cost her life in Sicily. So she came up to me and she said to me, "Oh, I want to tell you about ketamine and my phantom limb experience." And then she told me the story a bit, and I was fascinated. I meant to keep in touch with her. We lost touch for a while, then we got back. And I'll tell a story because, it's typical of the horrors that occur in so many ways, from accidents, war, overdoses, all kinds of things that take people's limbs off.
Diabetes.
Diabetes.
Yes.
In older people especially, one of the main causes of loss of limb. So Michelle had been on the back of a Vespa with her boyfriend in Italy, in Sicily, in fact. And they were on a very back road, no communication, no Wi-Fi, no phones working. And a little car turned the bend and the Vespa crashed into the car. Her boyfriend was unharmed. He was sitting in front, but the car took off her leg, pinning it in the car. And so she's exsanguinating. She's bleeding out, side of the road. They can't get help. And they had no choice. So her man and the driver of the car, which was barely damaged, drove to get help. She's lying there with a tourniquet, trying to restrict her loss of blood, and they get to help, and then she's helicoptered out. It goes through a whole series of attempts to help her, but she had an amputation. There was no ability to avoid that. And then she's left with furious pain for years and years. And Michelle is a very thoughtful person. She was on opiates. They didn't work. They gave some partial relief. And she began to explore the world of alternative medicine. And she started doing ayahuasca in Latin America. And that was great for her emotional issues, which were enormous. People whose limbs really often have tremendous emotional issues, PTSD, symptoms of involuntary recollection of the accident, but also just depression, losing a leg and coping with stump issues. People think it all heals easily. It doesn't. Stump issues are a tremendous problem for people with just infection and pain and irritation. The stump is not a natural organ, so it has all kinds of its own healing issues. So the ayahuasca was good for her, but didn't do anything. And then her boyfriend said, well, I've heard that ketamine might be useful. And she did what people do on the street, and she insufflated, put in her nose ketamine, and lo and behold, the pain went away. Completely went away. And she was having an enormous daily pain. And it went away for 6 or 8 months, I forget which. And then it returned a bit. She repeated that, and then she's been pain-free since. So kind of a miracle. So I heard this, and I explored this, told her story, and I said, oh, we need to do the protocol. So after the story was written, one of our co-leaders in the Albuquerque site, Lisa Fireman, who deserves a great deal of credit, had an amputee, and she decided to try ketamine. We didn't have a protocol then. She'd been in one of our training programs. And lo and behold, this woman was having relief of her daily phantom limb pain for weeks at a time, and that's continued. So she hasn't got full remission, but she's got much more of her life back. And that inspired me to create a protocol, which is involved with intramuscular use of ketamine over time, and a serious look-see at how ketamine may or may not affect. We're looking at 25 to 30 amputees of a various sort to come into the program, have this ketamine experience under very direct supervision. It's free, as you know.
Yeah.
And we're very optimistic to get going and see what this really can do.
Yeah,
So-
and I think it's really important for people in our audience and in the audience in a larger context to really hear about these stories, particularly because they're traumatic. And just from what you've just shared, I have a question around her experience as well as the experience of probably thousands of people who've had, an amputation, whether that was a result of an accident like this or due to infection or necrosis or, whatever the indications may be. What does phantom limb pain reveal to us about how the brain represents pain in the body? 'Cause it's fascinating because you have a limb, it's been now amputated. You would imagine as a physician that the pain should go, but why does it not go? What would you say happens in the brain?
I think the brain's a wild thing and extremely complex. And we don't have full answers to the, wonderful question you've raised. But what we can imagine and think about is that the brain is projecting the loss of the limb. It's projecting the occurrence as if it's happening.
Right.
And it's projecting it to the area that has suffered. So it's still locked in to its reaction to the loss of the limb. It's locked into this is still happening and you're in trouble, and it's giving the warning sign out of control.
Right.
Okay?
Mhm.
So it's an out of control response. It's telling the person who has the amputation that their leg is in the wrong position, something's terrible is the matter, and it can't stop telling the person that. It's stuck.
It's stuck.
Okay? It's stuck. So it can't get present. So what I think ketamine does is when it works, and we're not clear about how many people will be positively affected, that's our study. When it works, it tells the brain, no, you're making a mistake. This is not occurring anymore. It occurred. There's enough issues with the amputation issue of the stump and all the stuff. Let's pay attention to what's local and real and get over, projecting the horror that has occurred. So the brain is really a PTSD organ in that sense, in that it's perpetuating the traumatic issue on and on and on. That's a psychological view. Do I have a neurological explanation? I think we're working towards it, but I don't think so. And I think it relates really to neural nodes and the complexity of projections of form, not just of pain. So, there's form involved. there's a sense, oh, I had a leg, now I don't have a leg, or I had a hand, now I don't have a hand. And it's projecting the form as if it existed,
Mhm.
right?
As if an indicator of acute loss or break, or even that traumatic experience relived over and over again in the body, and the body is recalling
In the
it.
body. The body's keeping the score, but it's
Sure.
keeping the score at much too high a score, and the body needs to adapt. Not everyone gets phantom limb pain, but in terms of numbers, 2 to 3 million people in this country are amputees. A lot of vets coming back from war are amputees. We want to reach them. What we're doing is a demonstration that we think will affect lots of people. We have to see how it works for elderly people with, as you pointed out, diabetes, which is an enormous cause of amputation. But it also has so many vascular factors that I don't know that we know yet what it will do. And I would just add that ketamine is a very interesting medicine in terms of pain. It's very unpredictable. It works on, as we're learning, a variety of things like complex regional pain syndrome. Well, that's been fully explored. It works on status epilepticus, though it works on status migraine, though it can
Yes.
cause migraines. It works on fibromyalgia for some people. You know, it's empirical in the sense that it's not a one-to-one linear thing. It's a matter of, okay, we'll try this, we'll see how it goes, and let's see if we can get you a result. And then also because we don't have standards yet, we don't know what the dosages are that will do this. And they're pretty much across the board. There are various pain programs of different duration and dosage. You know, in some pain programs go 4 days with intravenous going, with ketamine going into people for over 4 days intermittently or even longer term.
Right.
So I think part of what we want to do, Alya, what you're going to do, is to help us come up with some sense of this is a relative standard that we can provide to people all across the world. The ketamine is a legal substance. It's a World Health Organization approved substance. It has no respiratory suppression at these dosages, which are called subanesthetic. It is really totally safe. It's one of the safest medicines around. That's why it's widely used for anesthesia, because it doesn't suppress breath. And so it's a very safe approach, and I hope we will learn how to really help people with this very great difficulty.
Yeah, there'll be many questions hopefully answered. One is kind of the protocols, the standard, what is the best approach in this process of management of a pain patient who has this experience. The other factor that I feel very curious about, well, the question of this patient that you described, being on opioids and not having a response to something
or partial.
partial. What is it you feel about ketamine in particular that may affect that NMDA receptor modulation, the neuroplasticity, or do you feel like this has to be more complex with that sense of perception and consciousness related to pain? It's a complex topic, and I probably opened up so many more questions around that. But I'm just very curious of why ketamine and its, receptor approach to pain, how does it make it unique when it comes to other pain medications in their response and that neuroplasticity effect?
I mean, I think that's a very good question. The mechanism is different. So opiates work at a different level. Ketamine may have an opioidergic effect, it's called, downstream, but it's not primary. So it's not working on mu receptors and what opioids do.
Right.
It's working at a different level. It's working both physically in the neurological sense, and it's also working in the psychological sense. Both come together. I don't think we have a clear answer on the mechanism of pain reduction. But remember, we're not talking about pain reduction in general. We're talking about the anesthetic effect of ketamine, which is part and parcel of the whole thing, but not causative of the relief of pain. Now, if you put someone to sleep and an anesthetic dosage, they're not going to feel pain. And that's often done in battlefield situations where if you gave someone opiates, they're going to have reduction of pain, but they're going to be conscious living through the trauma the rest. You give ketamine in that kind of acute accident situation or military situation, people are anesthetized and they will be awakened at various points. So the mechanism of action seems to be both psychological and at neural net level, and it's not at a pain level per se.
Yeah.
So it's somewhat different.
Right.
Somewhat different.
I had a patient who came in for ketamine treatment, but not really because of phantom limb, but did have a missing digit from an accident injury. And the reason why that patient came in for ketamine is because for treatment for depression, because, when they cut their finger and amputated their finger, they were given ketamine in the ambulance. And they did not even care about losing that digit. Because they had received ketamine, they didn't even feel the trauma of that experience at the time. And they felt, well, yeah, this happened to me, no problem, I'm alive. And so ketamine worked for that patient, particularly for that traumatic event in that timing. And I've seen this with ketamine in the emergency room as a hospitalist, where ketamine is given in situations and the side effect of that is, hey, that patient is calm. When it could be the opposite in that acute situation. So I'm very curious about, what is it about ketamine in general that gives this sense of disconnection, that dissociative effect to that experience?
I think at some point the person awoke to the fact they didn't have a finger, or someone wakes up that they're missing an arm, and then they're really struggling with what they may not remember the acute trauma, the explosion, the car accident, but they're going to eventually cope with, I'm missing a limb. And that's not going to be easy. So I think what ketamine does is it anesthetizes and puts a distance between the event and the awakening. And that distance is made up by us as practitioners. How long do we keep someone in that state before we bring them back and they have to deal with the pain, the loss of limb or whatever, which is going to be difficult eventually. So it's the memory of the trauma itself which tends to be lost and suppressed. But you're raising very good questions. Somehow I think it's, at the level of perception of pain that ketamine works. I don't think it's at the peripheral nerve level, at the local nerve level. It's brain. And
it's all brain.
I think it's central brain, and it's changing the whole nature of the experience of pain rather than, the location of pain.
Correct.
Per se.
Yeah. Kind of ketamine interrupting the pain signals, but also helping the brain remap itself, that sense of reality it has with that pain, would you say?
Yeah, something like that. So I think as we work with people, we're going to learn more about, because this is really our interest. Our interest is not just can we figure out how ketamine works, but if we can figure out how to help people in a program with ketamine. And, let's make sure we tell people how to find us. So people who want to join our protocol, we have 5 locations, and people have to be within 50 miles of a radius of those locations. One is where you are in Sacramento, Alya. I'm in the Bay Area. Another's in Albuquerque. Another is in Los Angeles. And another is opening up in Milwaukee area. So people can't participate in them unless they're able to get to us, hence the requirement for a 50-mile radius, assuming people could drive to be with us. To get to our protocol, either contact us through the Ketamine Research Foundation, or you were registered and now receiving patients at clinicaltrials.gov, which is the government registration for new clinical trials where anyone in the public can go and look, phantom limb pain, look, they're doing this, I can get in touch with them.
Yeah. Walk us a little bit for patients who might be curious, what would this entail for them in terms of being registered? What's the expectation for them? How many sessions?
They have to be 18 to 65. They have to have a medical doctor in the background. Of course, we're not doing medicine directly. We're doing the protocol. They have to agree not to drink or use alcohol or marijuana for 24 hours. There are various ways in which we isolate the use of ketamine in the protocol so that it's not affected by other substance use. They can be on opiates, so there's no requirement. There's a dose limit on opiates. So we expect that people are going to come to us who are in pain and in difficulty, and we're not trying to get them off all meds. We're trying to see the effect of ketamine, which happily is not affected by many meds, so that people can be on it. We can't take people who have significant cardiovascular histories or are, acutely hypertensive. But we can take the bulk of people who have amputations, and they will have to agree through our informed consent to participate on a regular basis. They can withdraw from the study at any time, but they're going to have a complex intake so that we understand background, and then they're going to have to be available to receive the ketamine twice at least so we can see what the effect is, and then on an ongoing basis. The ketamine requirement for a sense of success is that someone has a remission for at least 7 days. So if someone gets relief from ketamine, partial but significant, or has full relief for 7 days or more, that's a success. When they have recurrence, some people may never have recurrence. We forgot. But those who have recurrence after 7 days will come back for further treatment. The length of the whole program is 6 months. Anything else you would add?
I think just having a place for patients to really access, and you mentioned ketamineresearchfoundation.org. They can contact and learn more about how to become a patient or how they see if they qualify. The clinicaltrials.gov, I imagine, has a searchable way of looking for ketamine trials that are available and then
Correct.
Provide that accurate information based on patient location.
And if they want to contact you directly at your site, to give them that info.
Yes, they can contact us at info@shahminds, SHMYNDS.com. And I'm Dr. Alya Ahmad, and this is Dr. Phil Wolfson. And again, email us, contact us on our website, www.shahminds.com.
So I would just leave us with a sense of people with a sense of optimism. I think this is really going to be beneficial. I have enough information to suggest that it's really worth people struggling with phantom limb syndrome to come and be part of this, because I think there's a very good chance that their lives will be measurably, and I hope immeasurably, improved. So do contact us to be a subject in our program.
Yeah, and I imagine that this just opens the door to all the implications of pain that you mentioned. Chronic pain syndromes, fibromyalgia, emotional pain that's stored in the body as well, and how we really are treating more than just, as you said, the pain, whatever pain means in phantom limb, and really bringing the intersection of trauma, the memory of pain, the physical pain, to the work that we're doing with patients in ketamine treatment. So I really believe that this is one way of really demonstrating the importance of addressing these topics. Again, as a physician, and knowing that, when we've had patients who've had diabetes and had amputation, it's something that you would think, and I've seen this in my own practice, the limb is, removed and the expectation is they should heal. And that is not necessarily the case. And so many patients are left with these unanswered approaches and unanswered treatments that aren't really discussed in our conventional spaces. So I really think this is also an opportunity for people like us, the physicians out there, to really learn about phantom limb and, to have our patients even teach us about what their experience in pain is. And that's what I feel I learn every single day from patients, is their experience of what it feels like to be depressed, and really exploring that in very open and creative ways. And I feel that phantom limb is another way to address that. So thank you for doing this. And I think it's important to the work in so many ways. I'm so glad that you're doing this and excited to be part of this project with you.
I'm excited to be with you in this project, and thank you for having me on this.
Yeah.
And blessings to everyone who's listening, and we hope you'll join us. If you know someone, and send us subjects, and we look forward to doing the protocol and reporting it.
And there's no cost to the patient.
No cost.
No cost. So this is fully funded. And again, thank you for doing this. And I really hope that we get a lot more out of this too in the exploration of ketamine in phantom limb. So this is the Two Curious MD podcast, where we continue to explore the edges of medicine, story. And I think story we cannot ignore. And in our chaotic world that we're living in, the AI generative medicine now, we have to keep the humanistic element of healing in medicine alive and well. And that's what heals. And so stay curious and keep asking questions, pushing the envelope and testing the borders of what are, of science. So thank you. Thanks for joining us on the Two Curious MD podcast. We hope today's episode inspired you to ask new questions and explore fresh perspectives. We challenge you to ask us those unasked questions that you're curious about in your medical practice, condition, health, and wellness.
If you enjoyed the podcast, don't forget to subscribe, share it with somebody just as curious, and leave us a review. It helps us keep the curiosity alive. Post or comment with a question or curious inquiry that you have and seek to explore or learn with us. Stay curious, and we'll see you next time.